Hello, friends, and I'm back again with some more reminiscences and contemplations about some paradigm shifts in the field of intensive care. If you want to talk about a paradigm which has spread across the various aspects of critical care and has made a difference to the way we monitor and deliver therapy to our patients in the intensive care, it's probably the point of care ultrasound. It's probably the true paradigm shift which we have witnessed in the last 20 years. When I began my career 20 years ago as a trainee in intensive care, the ultrasound was limited to cardiac echo, focusing on the left ventricular function. There were a few intensive care units even at that time which were looking at ultrasound as a means of guiding your vascular access, that was not a continuous or a real time ultrasound. You were marking the anatomy and then doing the vascular access. From then on, the vascular access being obtained through point of care ultrasound has evolved, and to the point that today positioning of ECMO cannulae and other highly invasive vascular devices is guided by point of care ultrasound. This has really made a difference to the safety of these procedures and probably has saved reasonable number of lives, although I can't give you a number needed to treat for this particular intervention. It's become standard recommendation for all intensive care society guidelines for vascular access. Similarly, the realm of ultrasound of the heart or cardiac ultrasound has also evolved over a period of time in the last 20 years. When we first started using ultrasound, we focused on left ventricular ejection fraction. Some of us used to look at the velocity time integral across the LVOT, and then we were looking at the pericardium and the regional wall motion abnormalities. Pretty much what the cardiologists would also do. But as the understanding about the value, the role, and the importance of the right ventricle in intensive care grew, more and more emphasis was laid on intensivists learning the nuances of assessing the right ventricle, the right ventricular strain, for example. To some extent, credit should go to the work done in the field of pulmonary embolism, which actually showed that the tricuspid annular plane systolic excursion is a good sign that your RV is not working well. The same logic was then applied to other areas where the right ventricle is under strain, like ARDS and hypoxemic respiratory failure, where a worsening tricuspid annular plane systolic excursion is an indication that your right heart is working against increased upstream pressures. As we progressed and as we learned more and more about the way the ultrasound can be employed, it became a standard part of assessment of all patients with shock, and we developed the tank, pipes, and pump concept. So we were able to look at the blood vessels, we were able to look at the heart, we were look at the great blood vessels of the thorax, and then understand what could be the etiology be for a patient presenting to emergency room with shock. So the role of ultrasound as the primary screening tool for patients presenting with undifferentiated shock has also probably streamlined the way we utilize other investigative modalities and prioritize what we do for our patients presenting in shock. And that's probably been a very significant and useful paradigm shift as far as ultrasound of the heart is concerned. While we still look at tamponade, we still look at pericardial diseases, we still look at ventricular free wall rupture, we are also looking at the right heart, its function, and its upstream performance using ultrasound. So that's probably been a good paradigm shift as far as cardiac ultrasound is concerned. Another area which probably has progressed by leaps and bounds, and you can say something which could not be imagined 20 years ago, is lung ultrasound. Ever since Liechtenstein proposed the Blue Protocol, a lot of this assessment of lungs with hypoxic patients has been based on lung ultrasound. And it's now become a standard practice to have an ultrasound done on every patient in the intensive care who has suddenly dropped his saturations or dropped his PaO2. And it's a replicable model, and it's easily storable, and it is documentable. So, simple documentation of a few parameters like the B lines would exclude a life threatening problem like a pneumothorax. Instead of wasting time waiting for a chest x ray, doing expensive investigations like an HRCT, or doing potentially dangerous procedures like a chest drain in a hemodynamically unstable patient. From assessment of hypoxia, the lung ultrasound also progressed to assessment of patients who are on treatment for hypoxemic respiratory failure, read ARDS. So when you put these patients on mechanical ventilator support and try to recruit the patients, was the recruitment successful or not? Is your PEEP effective or not? Has there been de-recruitment for the patient? And if you prone the patient, has the prone ventilation succeeded in recruiting more areas of the collapsed lung? This information was not readily available, although subsequent information through driving pressures and other parameters can be obtained as surrogates, but physical demonstration of resolution of a confluent B-line profile to a less confluent B profile is probably more elegant way of understanding that you have been able to open the lung in the true context of the word. So it has also become an integral part of delivering therapy for hypoxemic respiratory failure, not alone diagnosing patients with acute hypoxemic respiratory failure. ARDS, of course, has got a lot of other problems like pneumothoraces, barotrauma, pleural effusions. So all these confounding factors for a patient with ARDS can also be identified and documented and probably be quantified using a lung ultrasound. Once your patients have been on a machine, you're always trying to wean them off ventilatory support. And the area of weaning has always been an area of intense investigation amongst researchers in the field of intensive care. The rapid shallow breathing index, the biomarkers, the cardiac function, they all have become points of research. Now, the role played by the diaphragm, its contractility, its stretch, and its shortening fraction as a contribution or a contributor to weaning success or weaning failure have also now been properly documented with the use of diaphragmatic ultrasound. So, a combination of a diaphragmatic ultrasound and assessment of right heart function during a weaning trial can predict which patient of yours is actually going to sustain an extubation after satisfying a spontaneous breathing trial, to the point that there have been suggestions that we should have something called as a diaphragmatic rapid shallow breathing index to quantify those patients who successfully withstand the process of liberation from mechanical ventilation. For those unfortunate patients who don't actually sustain this test and get hooked onto the machine for a long time, we usually go through a tracheostomy. And tracheostomies now are increasingly being performed under ultrasonographic guidance. We used to do them under bronchoscopic guidance before, but the paradigm is now shifting towards ultrasonographic guidance for tracheostomy. Emergency airway access also has progressed to the point that we now confidently can secure an emergency airway with the help of a tracheal ultrasound. One difficult area where point of care ultrasound has probably taken a longer time than other areas is neurocritical care. Transcranial Doppler has always been available in the hospitals and has been used in certain specific situations like subarachnoid hemorrhage. But with the advent of portable machines, the more easily available portable probes and the more widespread availability of training programs, training the intensivists in the art of transcranial Doppler has brought this test into the intensive care unit to screen patients with multiple other disorders like traumatic brain injury, for example, like an in-hospital cardiac arrest, for example, and acute ischemic strokes, for example. In all these areas, the transcranial Doppler has found some application as far as its role in understanding the cerebral hemodynamics is concerned. One interesting aspect which runs hand in hand with the transcranial Doppler is the optic nerve sheath diameter. It does have some caveats and it does have some concerns about using the optic nerve sheath diameter, but it is probably a good screening tool combined with transcranial Doppler to identify those patients who probably need more advanced hemodynamic monitoring, cerebral hemodynamic monitoring. So it is probably a good paradigm that ultrasound in the form of a TCD and an optic nerve sheath diameter has now come into the hands of the neurointensivists. When it comes to gastrointestinal intensive care, gastrointestinal aspects of intensive care, ultrasound did not find much role till recently when we started using it for placing nasojejunal tubes and nasogastric tubes. It's a very reliable tool to actually place a nasogastric tube under sonographic guidance. The other area where the use of ultrasound has become very clear and very useful is in assessment of gastric residual volumes. We usually tend to interrupt the nutritional therapy for our patients in the intensive care going by a gastric residual volume aspirate, but the ultrasound is a more reliable and more sensitive tool to tell you whether there is gastroparesis and there significant gastric residual volume. The assessment of the portal vein and its flow characteristics has also become an integral part of assessment of patients with fluid overload and with chronic liver disease in the intensive care unit. While assessment of the portal vein diameter and its correlation with chronic liver disease is the realm of the qualified radiologist, the assessment of the portal vein Doppler form or the Doppler trace is a part of the VEXUS protocol, which tells the intensivist that it's time to relook at offloading your patients who are overloaded with fluid. So it therefore becomes an integral part of your hemodynamic optimization. In the aspect of renal patients in the intensive care unit, point of care ultrasound has always been, for a long time, has been a part of assessment of patients with oliguria. Although obstructive uropathy in the intensive care unit is one of the rarer causes of oliguria, with hypovolemia and hypotension being the more common and the more likely causes of oliguria, exclusion of an obstructed outflow with the help of POCUS is a first step in the assessment of patients with oliguria in the intensive care unit for obvious reasons. So it was always been a part of the tools available to us, and the portable machines have made it and have integrated it into most algorithms. Now, the point of diagnosis of acute kidney injury has again been a point of debate. We always have gone with serum creatinine based scoring systems and predictive scores for identifying patients with acute kidney injury, but are we missing some of these patients who would probably have avoided going into acute kidney injury by using some other parameters? Biomarkers are an integral part of this exercise in identifying those patients who have functional derangement before structural derangement in the form of who have structural derangement before functional derangement in the form of raised creatinine comes into the fore. So renal resistivity index is one such sonographic parameter which is being investigated to understand whether we can actually identify these patients who probably can be prevented from developing acute kidney injury. As I said before, assessment of fluid overload is now an essential part of resuscitation or de-resuscitation, and the VEXUS protocol includes the renal Doppler to know how far your fluid overload has gone, and the presence of an abnormal renal venous Doppler signal signifies grade 3 on the VEXUS protocol for fluid overload. So it's always been there. It has always been a good tool, and it's now come into the fore and become an integral part of assessment of patients in the intensive care unit. The sonographic vascular access has always been, as I said, was an integral part, but the nerve blocks, which sometimes have to be administered in the intensive care unit for some procedures, can also now be done with the use of point of care ultrasound. Nutrition, as I mentioned about the gastric residual volumes and nasogastric tube placement, nutritional assessment of patients in the intensive care unit is a difficult and often nebulous area. So assessment of muscle thickness of 2 or 3 different muscle zones and a graded measurement of this thickness over a period of time in the intensive care unit is one of the more elegant and one of the more effective ways of identifying loss of muscle mass, read as sarcopenia, in patients in the intensive care unit. So if you look at the paradigm shifts which ultrasound has given, or which it has generated, right from cardiac ultrasound to lung ultrasound to neuro ultrasound, nutrition, vascular assessment, fluid assessment, it has been a true paradigm shift. And the machinery which we use has also evolved over a period of time. The cumbersome big machines which had to be brought to the patient's bedside graduated into more sleeker and much smaller machines, to the laptop like sonocyte machines which we have been used to. And ultimately, the best paradigm I can see or I can claim is the availability of a single probe for all ultrasound. That is the butterfly ultrasound probe, which can do every ultrasound, including obstetric ultrasound, for your single probe, which is not a crystal based, but it's a chip based ultrasound connected to a tablet or an Android phone, which is brought into ultrasound or taking ultrasound to emergency rooms, operating rooms, and ICUs without the hassle of lugging around a heavy machine. That's probably the last paradigm I can see, and that will make ultrasound more easily applicable and widely practiced for the benefit of patients in the intensive care unit. So, friends, I think focus has been a true paradigm that has shifted and shifted for the benefit of patients in the intensive care unit. So think about it, and if you find that I've missed some more paradigm shifts in focus, please ping me, mail me, or call me on my number. Thank you very much and have a good day.